Thank you very much, Maxine, for the kind introduction and the introduction to this webinar today. It's a pleasure to be able to speak to you today about some insights into research that we're undertaking in a collaborative project in using modeling and simulation as well as machine learning to try and support the search for novel medical interventions to help combat this pandemic. So this is a BRCCH funded project. It's a collaboration between myself and my team here at the Swiss Tropical and Public Health Institute here in Basel and Professor Roland Regoes from the ETH Zurich. I would like to begin by acknowledging my collaborators who have contributed to the work ongoing under this BRCCH grant, as well as some work that I'll be showing in previous projects. In particular, I'd like to thank Dr. Andrew Shattuck, Dr. Monica Golombinu, and Dr. Guojing Yang for the work that I'm showing here today. So you might be wondering, in this webinar, we're talking about novel medical interventions. What is the added role of mathematical modeling and machine learning? So let me take you on a small little journey. So over the last 8 months, we've all experienced this pandemic in differing degrees. And it is at the very beginning of understanding how we will live and combat the novel coronavirus. We've seen a large variety of responses in different countries, and we've seen a large variety of use of non-pharmaceutical interventions. So these are your social distancing measures and contact tracing. And is without a doubt that we do need novel medical interventions, but we're still acquiring all of the knowledge on this novel disease, as well as understanding immunity, so how we might actually intervene with novel medical interventions. So let me pose you into a situation where you have been tasked with having to make decisions about where to invest on novel medical interventions. This means you've got an R&D budget and you need to prioritize decisions about which medical interventions to keep developing, which ones to test, and eventually which ones to deploy in your country. But you're not alone. You're also with many other stakeholders who are supporting these decisions, but also have conflicting ideas. This would include, for instance, your national health bodies, your authorities, your doctors, also the WHO, including also the people developing these novel medical interventions, which includes pharmaceutical companies, biotech companies, and academic institutes. And of course, the stakeholders are us who eventually benefit from these medical interventions. And we all have to balance factors to decide how we can combat the SARS-CoV-2. You have many medical interventions currently being developed from very early to later stage clinical studies at the moment. We know there's vaccines, and last week we also heard about monoclonal antibodies in this webinar. We've got diagnostics, digital tools, and also treatments. In the end, your decision on investing in these tools should always be directed towards a public health goal. What are we aiming to do with these novel tools or interventions? We're trying to prevent mortality, stop disease progression, limit introduction of this disease into a city. And this includes at an individual level and at the population level. So you and your stakeholders are balancing many, many factors. You need to make decisions about what do these novel medical interventions need to look like? And by that we mean, how efficacious do they need to be? How long of duration does our vaccine have to last to be useful to meet our public health goal? And you, as stakeholders, really do need to define what the unmet need is. And it's very clear with coronavirus what the unmet need is. We need to have additional interventions on top of our non-pharmaceutical interventions to ensure success. And that is where modeling can help support you balancing all of these factors. So mathematical modeling and statistical modeling means you have a systematic framework to put all of these factors in together, along with observational data from clinical studies or epidemiological data, to go beyond the factors that you're observing in the data, to use those models and simulate out to understand predictions, for instance, of these novel medical interventions. And it's modeling that can provide you some of this additional evidence to support your decision with your stakeholders. This modeling occurs in an iterative fashion as knowledge increases, as the question changes, and as the pandemic progresses. Modeling needs to iteratively try to provide additional evidence to support the stakeholders making these decisions. So where are we now in the disease pandemic? So we have had 8 months of experiencing living in most cities with the novel coronavirus. And we've all become very well versed in epidemiological terms and have seen what modeling can and maybe do, and its limitations in supporting understanding these outbreaks. It was very clear that it could help understand exponential growth. It can help understand case fatality rates. It can do short-term forecasting along with stochastic simulations. More recently, though, we're beginning to see what is the role of modeling to understand how can we intervene. Up to date, we only have non-pharmaceutical interventions. So that means social distancing, contact tracing, closing schools, and so on. And modeling here, how it has been used, is to provide some predictions, or what we call scenarios, of what could be. So we can compare scenarios of these interventions, for instance, of school closure compared to doing nothing, and so on. These are not predictions of what the future will be, they're predictions of what could be, so we can balance these factors, the differences between these interventions. So for novel medical interventions, the classical use of infectious disease modeling means that you develop models that take into account all of these factors, which includes your biological data, your epidemiological data, your understanding of your demographics, as well as inputs on what this intervention may look like. And these are these intervention properties, such as its efficacy, its duration, and we also can look at programmatic properties such as coverage. And by coverage, for instance, at a population level, this might mean how many people or the percentage of people covered with a vaccine. We can place these into our models that have captured all of these interactions, and many of them nonlinear interactions, to estimate the impact on health. And so this might be a certain outcome like disease prevalence or incidence. This very classical approach means that in general, we need to have some knowledge about these intervention properties. Otherwise, we have an extremely large number of scenarios to make these relative comparisons. And this means when you're developing very new tools, very early on in the development, we don't really have a strong handle on how long a vaccine may last, for instance, or how we're really going to target populations if we have supply constraints. So my group here at Swiss2PH, we have recently been reversing this analysis. And to support evidence to understand what the properties of a novel medical intervention needs to look like, we've placed at the center of our analysis our health goal. What are we trying to do? Are we trying to prevent mortality? Are we trying to reduce incidence? Are we trying to mitigate resurgence? So if a new coronavirus is introduced into a city, that it doesn't have exponential growth. So by putting this at the focus, we use our models, parameterized and with all available data and knowledge of the disease, we really then try to explore the intervention properties that would allow us to meet this public health target. This means with simple models, it's rather easy to do this. We can use a simple optimization algorithm. However, for coronavirus and many other infectious diseases, these models become quite complex because we need to capture the nuances of interactions between the interventions, the populations, immunity, and social behavior in particular. And so we've added machine learning into this process, which allows us to much more efficiently use these complex models. Machine learning here is just a statistical approach to understand the relationship between the interventions and our outputs. It means with complex models, we create what's called a computationally light emulator, which allows us to do analysis much more quickly than it would be without the emulator. But what it also allows us to do is pull out the relationships between our inputs, in this case, our intervention properties, and our health goal that we're aiming for. You may be used to machine learning being applied to data, to large, big data. And this is similar in the sense that our data is not health data, clinical data, but more model predictions from our complex models. What this also means, if you come back to my initial question of placing you as a stakeholder, having to make decisions about which novel medical interventions to invest in, that this type of analysis allows us to have some principles to inform what are known as target product profiles. And these are key reference documents for product developers to really make sure that when they're developing their vaccine or their monoclonal or their new treatment regimen, that they are really trying to meet this public health target that's been defined. So let me just quickly show you how we've applied this framework for malaria. So at Swiss TPH, we've got extensive history in infectious disease modelling, including malaria modelling, and we engage with many partners to answer questions to improve public health and to support the control and eradication of malaria. We have also engaged in providing evidence, economic and public health evidence, to support WHO recommendations of novel vaccines. In this case, we have individual-based models of malaria. So unlike coronavirus, malaria is a parasite transmitted by a mosquito. So these individual-based models capture the mosquito and the human dynamics, as well as the parasite, and also the interventions that we have already, which are more than just non-pharmaceutical interventions. There's vector control drugs and so on. We use these models validated and calibrated to extensive data. And we can use these then to apply the approach that I showed you just before to inform target product profiles of new malaria interventions. This looks like, this is an example here for an anti-infective monoclonal antibody. A monoclonal antibody, in this sense, if an individual is given the antibody, it protects you against infection. And we have a question, the question that we have to answer here for the product developers is, how long does this monoclonal antibody need to be active to be useful to add into our tools of arsenal to combat malaria? And here we were looking at prevalence reduction, so trying to reduce the number of infected people in the population. And we were able to give these landscapes to our partners at the Bill and Melinda Gates Foundation to provide some evidence of what would the duration of a monoclonal be needed to meet these targets. This means we assumed, for instance, a coverage of 60% and an initial efficacy, and we can start giving some estimates of required half-lives. But more importantly, we can go beyond that and start looking at this programmatic deployment. How did these requirements change if we look at the interaction with existing interventions, so deploying them with another existing anti-malarial treatment, or if we deploy them more frequently? So why do we need this framework for coronavirus and our current pandemic? So at the moment, we're facing quite some challenges. We have non-pharmaceutical interventions of social distancing, we have masks, we have testing, and we also have contact tracing. We try to isolate symptomatic individuals as well as their contacts to try and break the chains of transmission. However, we know that the novel coronavirus, SARS-CoV-2, has a very interesting and probably lethal infectivity profile where we are infectious before we have symptoms. So this makes it a little bit harder to identify people. They're pre-symptomatically infectious. And we also know that in some populations, in elderly or vulnerable populations, we have a relatively high case fatality rate compared to other coronaviruses. We also have challenges in defining the strategies that we should use at different national levels or local levels. Are we trying to manage the epidemic, or are we trying to suppress it? And suppress it means that we're trying to keep the effective reproductive number below 1. A number above 1 means that we have exponential growth. And these interventions that we have at the moment are costly and also difficult to scale. And we've seen varying degrees of success in different countries on how to employ contact tracing along with the other social distancing measures. The future we have in front of us is there's many vaccines and other immune therapies or diagnostics and treatments being developed. And our question is, how do we use these in conjunction with our existing non-pharmaceutical interventions or to replace them? And so we really need to answer these questions. And this is why we can apply this framework, because we can explore this large parameter space and nonlinear interactions between all of these interventions. So part of this requires having models that are fit for purpose for these questions. So as part of our BRCCH grant, we're developing and adapting existing models and also collaborating with other partners. At the moment, we've been developing population models and using these to explore the non-pharmaceutical interventions in Switzerland to have a really solid base on the disease epidemiology and transmission. So Dr. Andrea Shattuck here at Swiss TPH and our team here have been collaborating with colleagues at Harvard, Renee Niehaus and James Hay, as also with the European CDC to develop these population models that take into account disease transmission as well as disease severity and also hospitalization and ICU usage and so on. We account for different contact networks, age structures, and also allow for different geospatial structures by allowing us to parameterize and calibrate to different countries. And we also account for all of the non-pharmaceutical interventions that we have, which include testing, contact tracing, and social distancing and masks. Using these models means that we have a good base understanding to start applying our novel medical tools. So we have calibrated these models to extensive data, biological and epidemiological data from countries, and can make predictions of what has happened in Switzerland in the past to understand the role of the different aspects of the soft lockdown that we had. And moving forward, we can also looking at combinations. We've looked at combinations of non-pharmaceutical interventions. So for a vast array of assumptions of the effectiveness of these different social distancing or testing policies, we can start looking at how suitable are they really to reduce the effective number, reproductive number below 1 to aim for mitigation. And we do find it's terribly difficult, even with an efficient contact tracing system, without very high testing and very high mask usage, and really trying to have some level of social distancing to avert super spreading. So for this grant with the BRCCH, we are now developing on top of these models, individual-based models that really are necessary to be able to look at the nuances and interactions between these novel medical interventions. So we can apply our framework for defining these profiles of these tools that we need moving forward. And as part of this grant, I've only today just given you a small insight into the work that we're doing at the population level. We are also, of course, looking at the within host level, trying to understand new diagnostics, treatments, and immune therapies for individuals to halt disease progression. And we're collaborating with Roland Regoes in ETH Zurich on this aspect. Key to all of the questions that we're also asking is understanding cumulative incidence. So we need to understand the past epidemic. And as you're all aware, there's quite some serology testing ongoing in Switzerland and abroad. And he's going to talk to you about some of the heterogeneity that we're seeing in these. So I'd like to hand over to you, Roland. Thank you.
Yes, so can you hear me?
Yep, sorry, we can hear you, we can see you, we're all good.
That's great. So can you see this also?
Yep.
So yes, thank you very much for the invitation to talk here. And I will spend about 10 minutes to talk about a very specific project that we have been conducting with Judith Baumann, Julien Rioux, and Sebastian Bonhoeffer since about March. And as Melissa mentioned, this is about the cumulative incidence, so the true extent of the epidemic. And this is actually a very important parameter, especially if you want to do modeling, because that's where epidemiological models need to be anchored to get the numbers right. And as you may know, you can estimate cumulative incidence from serosurveys where you enroll a lot of people and perform serological tests on those. But the serological tests we have at the moment are imperfect, so you need some modeling and statistics in order to translate serosurvey data into the cumulative incidence. And we thought we speak about this specific project because it very nicely shows how the different levels that we are touching upon in the overarching proposal, the diagnostic level and also the within host level, are intertwined with the epidemiological level. So let me remind you of the many uses of serological tests that measure SARS-2 specific antibodies in people. On the individual level, you may use them to answer whether a person has been infected in the past, or you might wonder whether the person is immune now. These are two distinct questions. But on the population level, that is more interesting to us, you can ask analogous questions. One is about the cumulative incidence. So how many people have been infected so far? The other one would be about herd immunity. Is the population at a stage where the epidemic would be self-limiting? So here I talk about herd immunity as a state of the population, not about a strategy. And you see the problem that arises here is 2 out of 10 individuals in this little serosurvey are seropositive. But if you have imperfect tests, there, some of these might be false positive, some of these might be false negative. And this needs to be controlled for by statistical models. And we have corrections that go back many decades that control for the false positive and false negative rate, most notably by Rogan and Gladen. But there's also more modern methods under the name of Bayesian methods that factor in not just the false positive and false negative rates, but also how well we have estimated those. But in our work, we take a slightly different approach. If you look at these serological tests, they are often validated with people or sera from people that had the disease or did not have the disease. And they don't give you an output in terms of seropositivity or negativity directly, but they measure a quantitative response. And you see that there's quite a bit of variation typically in this measure within these groups, but also quite a bit of overlap between the groups here. So what test developers typically do is they introduce a cutoff that leads them to false positives and false negatives, dichotomizes the zero survey results, but this also loses information. So what we are promoting with our work are approaches that have been developed in the last decade by groups in the Netherlands that go under the name of mixture models. And they instead assign to each individual a probability of past infection depending on their particular quantitative measure. So here I just would like to show you some data, some actual data from a validation study conducted by Meyer et al. In Lausanne. And what you see is that there is quite a bit of overlap between people who had the disease and people who did not have the disease. And it is challenging to even define a cutoff. So the way we are approaching this is we conceptualize a distribution of quantitative test measures for cases and controls. And then we need a quantitative measure for the accuracy, which is basically a quantitative measure of this overlap of these distributions. So if you introduce some cutoff, you can plot the true positive rate against the false positive rate. And if you do that for all conceivable cutoffs, you get what is called a receiver operator characteristic curve. And the area under this curve is a good measure for test accuracy that is independent of the particular cutoff, very much unlike sensitivity and specificity. And in these mixture models, as I said, we are assigning a probability of past infection rather than saying somebody's seropositive or seronegative. So if you have a person with this particular quantitative test measure, then by looking at the probability densities for cases and controls and their ratio, you can define this probability of past infection. And what we use this framework for is we are conducting in silico serosurveys. So in these in silico serosurveys, we set a certain cumulative incidence, so we know what the cumulative incidence is, and then we sample from these two different distributions according to the cumulative incidence that we assume, and get some data that we analyze with the different methods. And just to be very brief about the statistical merits of these mixture models, they are superior to the cutoff-based models in terms of bias and in terms of confidence intervals. And they don't require you to define a cutoff, but I'm not going to show that here for the sake of being brief. But what I like to show you are some results that relate to the design of serosurveys that you can extract from this framework. The first thing we looked at is how does test accuracy affect the statistical power of serosurveys. And one of the conclusions we can get is that basically you need to enroll more people if your test is less accurate, and you can compensate for lower test accuracy to some extent, but not all the way. So if your test is less accurate than 0.9 of this area under the receiver operator curve, then this would require infeasibly large serosurveys. Another thing we can actually look at, and this is not looked at often in terms of power analysis of serosurveys, is the test validation step. So you might ask, how many negative controls and cases do you need to sample with your test to get a good idea of the false positive and false negative rate or of these distributions here. And what we find is that we need actually hundreds of controller case sera in order to estimate the cumulative incidence reliably. This is what some people do, but I've also seen groups that just use dozens. And the interesting thing about this is not about making the test more accurate. This is about getting very precise estimates of how accurate your test is. So just that makes the epidemiological inference better. And lastly, let me just touch upon something that we are quite excited about. And that's the fact that with these mixture models, you might get at mild and asymptomatic cases. So this is really something you couldn't do with cutoff-based models. So far, I've just talked about cases and controls, and then you can actually look at the serosurvey data and try to make out the cumulative incidence of these cases. But in truth, we have different types of cases. We have severe cases, mild cases, asymptomatic cases, and we know that disease severity is correlated often with the quantitative test measure in these serological tests. So what we are planning to do in collaboration with the people in Lausanne I already mentioned, and the Geneva serosurvey, is to estimate the cumulative incidence of severe cases and mild cases from the serosurvey data they collected. Actually, the people in Lausanne have measures for these quantitative test outputs for hospitalized and outpatient sera. So with this, I would like to conclude. I hope that this specific investigation gave you some insight into how the diagnostic, the within host and the between host levels are intertwined, and showed you that we need to understand these levels in combination to quantify, forecast, and also manage the epidemic. And let me conclude by saying that I'm really very enthusiastic to be part of this group of researchers led by Melissa Penny that covers many relevant aspects of SARS-2 disease dynamics. And with our combined expertise in epidemiological, within-host modeling, in silico clinical trials, and public health, in particular the scenario planning that Melissa mentioned, we are hoping to develop a decision framework to optimize medical interventions against COVID in the next years. Thank you very much for your attention, and we are happy to take your questions.